Welcome to Sports Ophthalmology, a podcast for ophthalmologists and trainees interested in providing eye care to athletes. Join as we hear from national leaders in this exciting subfield of ophthalmology.
Dr. Sridhar is a vitreoretinal surgeon and chief of ophthalmology at the Olive View Medical Center, part of the Los Angeles County Hospital System. He is also an assistant professor of ophthalmology at the Bascom-Palmer Eye Institute. He completed his residency at Bascom-Palmer and his vitreoretinal surgical fellowship at the Wills Eye Hospital. He hosts the podcast Straight from the Cutter's Mouth and is dedicated to educating the next generation of ophthalmologists. All right, Dr. Sridhar, thanks so much for joining us and welcome to the show.
Thank you for having me. It's a pleasure.
You have a wonderful podcast that I love listening to. I was wondering, how did you first get into podcasting and what are some of your favorite parts about doing that?
So that's a great question. Podcasting has obviously evolved a lot. I mean, podcasting has been around in various forms for about 20 years, but I think the popularity, if you chart it over time, just for recreational podcast use, for example, in the United States, it really picked up like early 2010s to mid 2010s, especially once you could listen to podcasts on mobile devices. Like, I mean, this sounds really old, but originally, if you wanted to listen to a podcast, most people were listening off their desktop, or they were downloading it and like uploading it to like an iPod if they're an iPod user. Smartphones sort of changed the game, right? Because they synced automatically and you didn't have to, there wasn't as much work required to sort of subscribe to a podcast. So I finished fellowship in 2016. And as I was finishing fellowship, I had gotten into listen to different non-medical podcasts, but I didn't really have much of a commute as a fellow, which was very, very nice. I knew I was going to be facing a significant commute as an attending, and retina doctors in general commute quite a bit. I think ophthalmologists commute more on average than other specialties in medicine. Within ophthalmology, retina doctors tend to commute even more because we are doing chronic long-term care with injections for patients who need repetitive treatments. And so as a result, if you look at the structure of most retina practices or even academic institutions that employ retina doctors, it used to be you were just at a home base, but over time it evolved to the satellite model where people would go and commute to their patients. Many of these patients don't have transportation, they don't have visual ability to go commute an hour or two. So it became a model, both though a business model and ethical model for doctors to go to their patients. So seeing sort of this unmet need, I did not think that I would be the one to try to fill it, but I was just interested in what resources there would be for myself to get educated. And when I explored it, there really weren't many resources at that time. There were a couple of podcasts that had sort of started and fizzled when you looked back. Like they had a few episodes in like 2010 or 2011. There were a couple of anterior segment podcasts, like Gary Wart's had Ophthalmology Off the Grid, which is a really fantastic podcast, but wasn't really specific for retina doctors. There was like one or two episodes out of a couple hundred that retina doctors would sort of listen to and learn from about their specialty. So I talked to one of my attendings and he suggested that I do it. And then I didn't really do much with it, but then I talked to another friend who said he was commuting like 2 hours to some of his offices, and he again brought it up. He's like, "You should do it. No one else is doing it." So that's when I started doing it. It sort of is. Everything has to line up for something like that to work, right? You have to have motivation, you have to have time, and you have to have positive feedback, right? And it was sort of the right time because I had just started my practice. I was not that busy clinically, so I had downtime to sort of read about it and figure out how to upload and put things up together and like build a bank of episodes and be very frequent. Like at the beginning, it was like 5 or 6 episodes a month, which seems crazy right now to be able to do that. I don't think I have the time to do that right now. And then there was a lot of feedback because, again, it filled an unmet need more than I realized that when I made it. And so it's been great. It's been 9 years this November that we've been doing it. It was initially 6 times a month, and it went to once a month for a long time. After my daughter was born, I cut down to 3 times a month. So my formula I tell people in my head is the number 4 equals number of episodes plus number of children. So if we have another child, then maybe I'll go down to 2 episodes. I think that's about the minimum you need to sort of maintain a following. But yeah, it's been very interesting and really a wonderful experience.
Yeah, that's a good point. There's definitely a lot of commute time to and from the hospital. And I love listening to podcasts during my commute. It makes me feel like I'm being efficient, I'm learning something, and also just makes me feel a little less alone. So I've really valued being able to listen to podcasts and enjoyed how many wonderful podcasts there are in ophthalmology.
And I think the powerful thing about podcasts, the reason I think many of us like listening to podcasts in general, you can listen to them anywhere. You could sort of multitask. I know multitasking is probably not the best thing for your brain in some ways, but if I listen to podcasts when I drive and when I work out, right? So I don't have to be 100% dialed into whatever I'm listening to. And I'm not going to be because I'm doing other things. But I think it's important if you have a medical podcast, unless you're creating it as like a study series where people are going to like study from it for boards or something else, it's got to be free flowing, casual. I think it's really important to have at least 2 or 3 people involved. I think monologues are really hard for people to listen to. I personally, even podcasts I subscribe to outside of medicine, if it's just one person talking for a while, often I'll skip that section and go to the next section. And I think that we're in an interesting time, right? Like what happened after COVID is there was an explosion of medical podcasts and medical content. And it made sense. People had a lot of downtime and people had time to think about. Maybe they had thought about the project and not done it. I think they were more interested in virtual teaching and learning at that time, not only Zoom, but audio. So there's been a lot more retina and ophthalmology podcasts that have been come up. And I think that's wonderful. I still hear often, and this is not to like pat ourselves on the back, I still feel often that people like ours in a certain need because we're one of the few or only in retina that's completely physician driven and then independent of bias. I mean, everyone has biases. So I think there are biases to myself or the people who come on, but at least the biases aren't from a funding perspective. And in other avenues, there is a role for funded podcasts. And I've recorded as a host for other podcast programs. Hey, we're going to do a funded podcast. Okay, great. I'll record. I mean, I try to keep my role within it ethical and sort of boundaried, but I've always tried to separate that from what we do in our programs because I think that's important for just the integrity and sort of the authenticity, right? I think that's why people come and listen. They feel, at least, even if they don't agree with what you're saying, that they feel that you're coming from a sincere place, that you believe in what you're saying, that you're not just saying things because you were paid to do it or you consult for this company or because you want to highlight something that someone wants to highlight. And that's a challenge. Like it's a good problem to have, but a lot of times as you get successful, one of 2 things can happen. One of those things is people start approaching you and be like, who'd be great for your podcast? This person. Or what'd be a great topic would be this thing. And it's wonderful, but then you have to think like, does it reflect the values that we want to do? And how do you say no in like a polite way, especially when there may be power differences there or it's someone very senior asking you. And in the end, you have to draw your lines, right? Like if you think it will be interesting for your listeners or you think it's something you're interested in doing, then you should do it. If it's simply because someone's trying to promote something or highlight it and there's some sort of secondary gain behind that for that person, then you have to be very careful because then again, you lose sort of your integrity. And people are smart and people know when you're being authentic and when you're not being authentic. I think the second thing that can happen is organizations can come along and offer to participate. And then it becomes an interesting question of how much do you pair up with an organization and what does that look like? And I think when I've talked to other people who have started podcasts after me, I've always kind of said, what are your long-term goals? You don't have to know them right now, but are you interested in doing this ad infinitum? Are you interested in doing this for X amount of years? Are you interested in like outsourcing this to someone else? But like ultimately, what was your goal when you did this and what are your goals? Because organizations can offer anything from simply, hey, we just like to post it on our website and put our stamp on it, but we're not messing with your content at all. That's great in a way because that's extra promotion for you. And if you agree with the values of that organization, wonderful. You want to pair up, for example, this podcast with some sports medicine organization that just co-hosts or posts it, that's wonderful. It's different if it gets into, oh, we really think you should have this guest on, or like, I think you should talk about this, this, or this, or hey, didn't really like what you said about this on this episode. Could you change it? And I think it's important to define those before to avoid situations where you end up uncomfortable, right? And is there added value to what they're doing? And very often organizations will come along and they'll just offer to take over. And hey, if it takes over and reduces burden for you in terms of editing, in terms of audio, in terms of scheduling, it may be 100% worth it to pair up with them to reduce your own burden, to continue and make it sustainable. If you don't need them for that, or they're not offering that service free, then the real question is, what is the value beyond, eyes? And what do they expect in return? And I think that expectation has to be defined because otherwise you don't want to end up in a situation where you created something and now it's not yours anymore. And now it belongs to someone else. Because I think most of us would struggle to maintain motivation. And that goes to the last point. Most podcasts fizzle out at some point. I don't blame people. It's work. It should be fun, but it is work to be consistent and to plan. And it becomes part of your life. Like I said, like it's funny to pair it up with my daughter, but like it has to be part of your monthly plan. There is no finish line unless you're planning a series of like, hey, we're only doing 100. And I've been very tempted at some moments to be like, okay, we're going to cut it off at this point, because it makes it easier. But if you're not planning that, you constantly need to sort of have a plan of where you're going. And it shouldn't feel like too much work. It should be stuff you're excited about, but you'd be lying. Just like training, and we're talking about sports in a second, just like training for a sport, like it's not always fun. Most athletes say the reason that high level athletes say the reason that they stop competing is not generally that they don't enjoy competing. It's that they don't enjoy the preparation that's required to compete, right? The training gets harder, the recovery gets harder. They love game day, but the week leading up to game day is more difficult. And at some point, it doesn't become worth it. And so that's really the question for this, just like anything, is like if you're not getting money back from it, which is one motivation for people, you have to be getting some other level of satisfaction. And if you're not getting that level of satisfaction, then you have to sort of reevaluate and think about, okay, like, is this fitting? What do I want to do with this going forward? So I think that's why a lot of them just sort of end. If you look at like Apple Podcasts, most podcasts that end, it's not like they had a final episode. It's just like there was an episode and then there wasn't one after that. And the longer it goes, the easier it gets to not post again.
Yeah, that's a good point. I definitely feel like you can pick up on authenticity when listening to a podcast. I've loved all the podcasts in the field of ophthalmology, and I find that as a trainee, pursuing residency right now, it's really fascinating to be able to get the experience to listen to ophthalmologists who are very well established in their career and discuss certain technologies or changes in the field. And you can gain really critical insights in a very approachable setting. And when there isn't an overarching conclusion, whether something's inherently good or bad, it feels more of like a discussion. And you had a recent episode that I felt like exemplified this really well, where you were discussing with your guests the advantages or the disadvantages of program signaling for the ophthalmology residency applications. And it's a great episode. If anyone's listening, definitely check it out. It really gives good perspectives on this topic. But I really loved that format you had because it made me feel like as a listener, I was at the table and it was more of just a discussion between you and your guests. I'm curious, what do you think the future of social media and podcasts for ophthalmology will look like?
I think organizations in medicine tend to be conservative. I think that's like an understatement. They tend to be slower to adopt new technology. I think journals and organizations in medicine will be actually really well served to start using platforms like podcasting or social media in a more effective manner. Like, and what I mean by that is it's one thing to be the head organization and post periodically a journal article, but it's another thing to give the transparency to that thought process, right? To show that you have leaders who are actively thinking about it. Now, obviously, it's way easier for me to just spitball because no one can point to me and say, well, that's the president of the American Academy of Ophthalmology, and he said all this stuff, right? I don't have that role. So it doesn't mean I don't take responsibility for what I say, but I don't have an organization that now takes responsibility for what I say. But I think that too often, the reason that people have issues with prominent organizations in medicine is they feel it's too nebulous and too opaque, and they're not really understanding. And I think they're not speaking the language of the younger generation of physicians and trainees. You need to talk to them in a way that's authentic, but also in a platform that they're going to consume. You can't assume just because you had a discussion at a national meeting that was a room with 100 people that everyone heard your message. You're much better off going to social. And I think like New England Journal of Medicine is a great example. Like Lachlan Flecken or is an ophthalmologist who's done all these social media things. They brought him in to do like these skits about recent journal articles, right? It's like a very creative way to try to educate people about essentially CME, right? They're essentially trying to give you CME, but in a funny way. And I think there's still like a withdrawal from some of us who were trained in an older era where we're like, well, if you really want to learn CME, you should just learn it, like do it the proper way. Why do we have to make everything packaged in like fun and games and a birthday cake? And it's just like, well, you could think that way, or you could start thinking like, you're competing for attention in this world. If you actually care about making a difference for patient care, then it shouldn't matter to you how the message is delivered as long as it's received on the other end. But that's an interesting sort of tension I see sometimes, is that there is a sort of a lack of understanding generationally. And part of it is because the technology, like I said, exploded so fast. I mean, it wasn't that long ago. I don't want to date myself, but I was in medical school. Podcasts were basically desktop only and iPods. And again, by the time I finished fellowship, it was smartphone, smartphone, smartphone. And it's only gotten more immersive as the technology has progressed. Yeah. And I think scientists, again, rebel against that because they're just like, they're like a lot of work and effort made into it. People need to critically evaluate the scientific merits of this paper. And I agree with that. I don't think this reading like the abstract of a paper is fair to evaluate it. You actually need to read it.
Yeah.
But I do understand also, and we all understand, realistically, most people actually just look at the abstract and the title of these papers. So you can either keep trying to convince people to read the whole thing, or you can accept that they're probably not going to read the whole thing. And then it becomes really important to make sure your title and abstract are accurate for what the paper says. So it's not just picked up by ChatGPT or one of these things to summarize in a way that's wrong, or a person reading it summarizes it incorrectly based on the abstract and title, but also, like you're saying, package it in a way that people will actually get the content that they need. And I think with AI, it's a whole different ballgame too now. Like you have to think ahead. I think in 5 or 10 years, podcasts will be a thing, but it's not necessarily good. But more and more of us are turning to AI, and AI is wonderful for a lot of things. Chatbots, things like that, can be really accurate. But I think we also know that when we ask AI about things that we know about, then we see all the errors that are there. And that makes me think of all the times I ask about things that I don't know about, that I'm just assuming it's correct because it's eloquent and it's organized and it's formatted in a way that's really friendly and the font is really friendly. But medical information is going to be done that way. And if you ask AI chatbots medical information, it's all over the place for ophthalmology, for example. And it's not accurate, it's not correct, but it says it with such a degree of confidence. And there's no confidence meter, right? It's not like AI spits out an answer and it's like, well, there's a 65% chance this is correct, even though it probably could produce that. Because if you think from a business model perspective, if you want people to use your AI and collect their data, you don't want to express any lack of confidence. You want to express full confidence because then people are more likely to come back. But I think it's an interesting next wave is like, if you're thinking ahead for education, podcasts are great. I think to supplement that, you really have to get ahead and start thinking like, should the AAO have its own AI chatbot that it can regulate? Should any or medical organization have that for its own members and for patients? Because at least then you could regulate the in and out. The problem again is, and I'm not saying I'm an expert, most of us don't understand it. And these organizations aren't outsourcing it to people who understand it. So I think we're going to become victim that everyone's just going to go to the most common AI engines, right? But if you're thinking like ahead, like if your generation's thinking like, oh, how do you sort of stay ahead of misinformation, things like that? I think the next step is you want to make sure your AIs are accurate. And sometimes the only way to know that is either to partner with a major company or to sort of use the technology to develop your own AI where you can be in charge of what information goes in and out, rather than it just randomly pulling whatever it wants from the internet.
And I always wondered about the accuracy of AI because when you ask for the AI to generate images, they're always really incorrect.
And they're very creepy. They're always just like, I don't know, maybe it will change, but I just feel every iteration, they're just slightly off. Like, it's like maybe it's a human assumption that we would be able to tell the difference. Maybe I guess there will be a point where we can't tell the difference, but they're always like, there's just a little bit wrong. Sometimes really wrong, but even the ones that are close are a little bit off. But yeah, I know. I mean, I think the idea, like you're doing this ophthalmology, like sports medicine podcast, I think it's important, right? Because I think there's so many intersections of sports and medicine, right? I think there are two major ones. The first major one is obviously we take care of patients who are either athletes or got injured in an athletic pursuit. But the second is I think people have started to wrap their heads around preparation as a physician, especially as a surgeon, as most ophthalmologists are, isn't that different than athlete level preparation, but we haven't treated it that way in a way we teach people how to prepare and go about their business. And I would compare it to longevity in sports has extended significantly, right? Like if you look at the longevity, like one of my favorite sports is tennis, right? They used to say when I was a kid, like a male or female tennis player would be basically if they're past 25 or past 30 for a male tennis player is like they're done, right? That their prime is over, their career's probably done. And now you see tennis players in their 30s who are professionals who can keep going to their mid or late 30s, right? That's the advancement of sports medicine. That's understanding diet and recovery and stretching and Pilates and using all these devices, massage guns, all these things that can help you extend your career, right? Whereas there just wasn't that understanding in an era where people would play tennis and then go and smoke and drink instead of recovering, right? And I think the same thing is true for surgeons. You know, there's always been a mindset in medicine that, hey, you just power through everything. And I think there is a lot of resilience in medicine, and you do have to do things that are not asked of other people. But athletes do that too. Athletes will, run around and play overtime, right? They'll go back-to-back nights for games. They'll do things in required moments that require high levels of intensity. But they now understand that the recovery is super important if you're going to sustain that. And I think that we have not, as a field in ophthalmology, for example, really taught that to our children, our next generation well. And there are people who have sustained it, but it hasn't become like a formalized curriculum of how you do that. But I do think like just you could prescribe the same sort of things for surgeons. Like here are the exercises you need to do. Here are the stretches you need to do to prevent yourself from getting cervical problems, which is the most common reason that ophthalmologists retire early is cervical problems. Here's how you protect your lower spine during and after surgeries. This is how you should be eating on surgery days. This is how you should be hydrating on surgery days. This is how you should be sleeping. And we just haven't had that sort of package yet. And I think about that all the time because I've tried in the last few years to try to communicate to our trainees. If you want to have a long, successful career, you got to think of it as a marathon, not a sprint. And I've been very guilty of sprinting all the time, clinic, taking shortcuts, skipping lunch, all these things, but they eventually will catch up to you. And it's not a sign of weakness. It's just the realities of physiology in the human body. And it's no different than being an athlete playing a sports game and being up all night partying afterward. You can do that. And there's famous athletes who have done it, but there's a huge drop off in their productivity over time. And that's no longer the standard. The standard is sustain excellence. And I think for doctors, that's sort of, and surgeons, instead of being a surgeon who's in pain or a surgeon who, goes to substance abuse or a surgeon who doesn't adequately even mentally prepare or is not having a healthy home life, for example, because they're internalizing all the problems they have. There is sort of healthy outlets that you can find. It's always been there. Now we have the tools to sort of put it all together and package it. And again, as a field and as a specialty, I think medicine and ophthalmology at the older levels are still a little bit resistant to that. They're resistant to sort of the terms burnout. They're resistant to the terms wellness. These things have like a mixed connotation to them. There are signs of Gen Z and millennial weakness. But in reality, you should just view it as evolution. You should just view it as, hey, like this is the next step. If you want surgeons to be functional and practicing for a long time and being healthy at home and at work and being able to offer patients like good bedside manner and a more difficult system to practice, how do you make this more feasible? Well, there are changes at work you can definitely do systemically to the medical system, which is, again, a whole other conversation. But individually, there are things you could take from athletes that you can incorporate that would help you as an individual mentally prepare for surgery, psychologically be ready for complications and how you respond to them without freaking out, recovering from surgery mentally.
Yeah, that's a good point. I think so many studies could be deduced to a bottom line that you could get quickly on a social media type platform. What kind of studies can we do in ophthalmology that will help better understanding of treating surgery as a sport and maintaining longevity in the career?
We did an ergonomic study. We used like one of those like simple ergonomic measures. That's again probably dated at this point a few years ago at Bascom. And it was interesting because there were two components. One is you can measure people's posture during surgery passively. And on average, again, people's posture is worse than you'd think during surgery. And then there's a training component where you have them wear it, but anytime they're not in the right posture, it buzzes and reminds them to get a better posture. And it was a very small pilot study with residents, but like you show that, yeah, if you have the feedback incorporated, people's posture tends to improve when they're like when you go back to a passive mode, right? But I thought the most fascinating thing from the study was we had one person who almost broke the study because their posture was 100% perfect all the time, even before they started, right? And this person who's a retina specialist now, an awesome person, was a former gymnast, right? And like had just this natural sort of perfect posture all the time. And that's reflecting the point that it may be harder or more difficult for some people, but it is possible, right? There are people who maintain perfect posture during really difficult surgical maneuvers. I am not one of them. My posture can suffer really greatly. I've gotten a lot of benefit out of incorporating physical therapy techniques, incorporating regular stretching, incorporating foam rolling, sort of massage gun type of techniques. All those can really help you instead of just being in pain or not acknowledging that you're in pain, which is worse. And then, you get diminishing returns, right? And ultimately, if you're talking about patient care, if you're a patient, would you rather have a surgeon who's like well rested, well fed, well hydrated, and ready to go? Or would you rather have a surgeon who's just running around, running on empty, and just squeezing the last drops of energy every time? Obviously, in certain circumstances, it is required to do that. If you're on an overnight emergency case, if you're a trauma surgeon, if you're in the middle, like certain specialties don't have the advantages that ophthalmology does, where ophthalmology is primarily an outpatient specialty. But there is sort of something that could be captured there to your point. Like not only could you capture, hey, it's better for the doctor, but I also wonder if long term, if you ever could capture longitudinal data, if you'd find it's probably better for the patient. I think most of us have very poor insight into our own selves. And I think we have poor insight when you're tired into the fact that you may not be performing or making decisions at the level that you'd want to normally.
I've really enjoyed reading sports ophthalmology research papers, and you had one I particularly liked where you categorized different sports related eye injuries as either minor or major, and if they occurred in the anterior or posterior segment. I think that's a really interesting distinction to make, and I was wondering what your inspiration was behind the study and how we can apply the data and results.
Well, I love sports, so it's a nice intersection of two things I love. I have to give a lot of credit to our whole team. that put this together, including Vishesh Patel, who was first author on that paper. I think it's because it's an under-discussed within medicine subject. I think that ophthalmologists understand this, but I don't think general doctors talk about with their patients eye protection. Eye protection is underutilized throughout sports. And so it was a good way to just sort of passively capture what are actually the reasons in the sports associated with why people go to an ER, for example. And it was interesting, basketball makes sense, right? People get poked in the eye a lot. And so those injuries don't tend to be serious, but they're very common. And so you imagine if you had someone who is higher risk for an eye issue, for example, a patient who's very high risk for retinal detachment, that you have to start thinking about, like, they probably should be wearing eye protection, right? If they have a family history of retinal detachment and they want to play basketball, it doesn't mean they can't play basketball, but they can wear goggles. And there's actually in sports sometimes a weird stigma, right? Athletes don't like wearing eye protection more than sometimes construction workers don't like wearing them because it can be uncomfortable, it can be poorly fitted. There's a little bit of a stigma. You have to remember to take it on and off. It's a whole process. But I think it's on us as medical providers to sort of emphasize the importance of it to parents or to those athletes as they grow up, right? And I think the serious injuries is interesting to think about too, right? The most common sports associated with serious injuries, you know, soccer is not something that people think about a lot. And soccer is interesting because people always assume it's related to the size of whatever's entering the orbit, that a ball like a soccer ball isn't a big deal because it can't enter the orbit. But with soccer, it's probably the repetitive trauma, which is voluntary. People head the ball all the time in soccer. That is a coup contra coup on the retina over and over and over again. And again, for many people, it's probably not an issue. But if you have someone who's high risk, we've had multiple series of patients with retinal detachments associated with soccer. And so it's just something that isn't really, I think, in the awareness. And that's an interesting one because eye protection probably doesn't save you from that. There really isn't anything that's compatible with that sport that saves you from it. But maybe it argues for screening. If you're going to have people in a professional soccer league or even a very competitive high school or middle school soccer league, maybe they should all get like screening of their eyes, like an eye exam before they start. Because if someone's really high risk and they are doing that, then they're at higher risk to get a permanently visual and altering retinal detachment.
So do you think the fact that maybe they don't quite notice that they're getting an eye injury contributes to a worsening prognosis?
Yeah, so that's interesting. So, like, for example, retinal detachments aren't super symptomatic often. Like, people, like, there's no pain associated with retinal detachments. There's no discomfort for the most part until it's late. Patients with retinal detachments present generally, they can be asymptomatic, or if they have symptoms, it can be subtle symptoms. They can be seeing more spots or floaters. They can be seeing little flashes of light sometimes. They can be seeing a missing part of their vision. But especially if someone's young, and a lot of soccer players and athletes are young, often the retinal detachment is not fast moving. It's a slow sort of chronic issue. And our brain is so amazing in its ability to adapt to chronic problems. And that's good, but it's bad because of the suppression that results. So someone doesn't even realize they have a problem until either it gets to the point where it affects their central vision, and then they notice it, or they get picked up on screening and someone says, well, you've had this probably for a few months to a year, right? So that's definitely part of it. And there's, like you said, there's no direct eye injury, and it's not even related to anything you would consider traumatic. It's just a normal part of the sport. But it is something that I think about because, again, it's not a high percentage of soccer players, but when it does happen, it's a more serious type injury.
What are some of the most common sports-related eye injuries that someone who wants to pursue a career in sports ophthalmology should be well-versed in order to diagnose timely and treat accordingly?
I have friends who work, for example, as most NBA teams carry a team ophthalmologist now. And I've had friends who've worked as team ophthalmologists. Two most common reasons they'll get called to go to the locker room like to see a player is a lid lack, right, from an elbow or something like that, which needs sutures or steri strips depending on the size, or corneal abrasion. And corneal abrasions are one of those things that are very difficult for players to power through because they're uncomfortable and they heal, right? So those aren't as big a deal. But I think it's we've had basketball players who developed retinal detachments who need retinal surgery. This isn't like breaking any HIPAA rules, I think. But like Anthony Davis, who was on the Lakers and then traded to the Mavericks just last year, he was reported in July that he had a procedure over the summer for a detached retina, right? And then basketball is also interesting because there's a percentage of basketball players who may have some genetic mutations that predisposed to being taller, but also predisposed to retinal issues, like being on what previously was deemed like the Marfan spectrum, but really the fibrillin 1 gene mutation spectrum, right? And that's a small percentage, but like a great example of that was Isaiah Austin, who was an NBA draft pick or potential NBA draft pick. And Isaiah Austin had a history of multiple detachments, but it wasn't picked up until pre-draft screening that he also had a heart issue. And then they realized he had Marfan syndrome. And like going back when I heard that story, it's obviously easier for me as a retina doctor to think this way. But I was just like, if you have a young, really tall person with really long limbs and like hyperextensible limbs who has retinal detachments, you got to start asking that question. Like, are they on the spectrum for Virilin-1? And if they are, they should get cardiac screening because they can die, right? There are very few things that can cause a high patient to die, but that is one of them that's sort of peripherally related. So I think basketball is an interesting one because you will think about it, you'll hear about it more often than not. There's been several prominent NBA players who have had retinal detachments and gone back to play, and then they wear their eye protection, right? And it's pretty much, I think, mandated at that point they should be wearing that eye protection for life if they're going to play.
Do you ever feel like the posterior segment is sometimes forgotten about when it comes to diagnosing sports-related eye injuries?
That's a good question. I don't know if it's forgotten about or it's not as emphasized because it's not visible. It's
Mhm.
just back to your point about symptoms. It's just not visible to the naked eye. You don't see redness, you don't see irritation, you don't see pain, and they're silent problems. But that's a great point. I'll tell you anecdotally, we've had players who have had eye injuries. Many of them, especially in sports with non-guaranteed contracts, they're first of all, athletes want to play, right? Most athletes love their sport. They don't know what to do when they can't play it. So if you tell them they can't play, they are hankering from the moment you tell them they can't play. They're asking you almost daily when they can go back. But the second part of it is there is a financial sort of thing and there's HIPAA and there's all these concerns. So a lot of times players want their own doctor, right? Because they don't want the team to know that there's a potential issue. And then you have to release it to the team. It's this whole, so like this is like the weird intersection of medical ethics and medicine and then the business. Ideally, what you recommend should be objective. It shouldn't be matter whatever. Been in situations where what you document is very important, because there is going to be a fight over insurance money. There's going to be a fight over, hey, can this person play? Oh, we don't want to take the risk. Sometimes a team doesn't want someone to play because they'd rather collect the insurance money. Sometimes the player wants to play even though they shouldn't be playing because they're worried that their spot's going to be taken by someone else and they're going to lose potential income. Many of these players don't have their own independent disability policy, even though they probably should. So like these are all sort of inherent issues which would probably be blocks to screening. Although, to answer, is a long answer to your question, I do think screening makes a lot of sense. Like I think it should be part of the baseline. Optos is so ubiquitous right now. Any sort of player who's being looked at should get screened. But it's just interesting whose interest is in that end and who is paying for the screening and who gets access to that information. Is it the team or is it the player? Because their interests are not always aligned.
What do you think some benefits are creating a niche like sports ophthalmology and discussing between people who like find this really interesting?
I think it's standardization. I think that it's the best way to have any system is you have standards that you can then individualize off of. So it'd be great to have some standardization across the board so that if a player gets injured in West Coast City X one night, or he has the injury in East Coast City X the other night, that the treatment shouldn't be drastically different. And I don't think it's drastically different, but maybe what they're hearing in terms of recovery time, what they're hearing in terms of recommendations, may be slightly different doctor to doctor. And it'd be kind of nice, if you had like, think about it, there's 4 major sports, let's say, and there's other sports, but 4 major sports. At the very least, the NBA has sports ophthalmologists and the NFL has sports ophthalmologists for each team. Like maybe that already exists, but they all sort of met periodically and they all sort of had guidelines that they followed. It makes it so much easier. And also it means that as the individual doctor, you're not on an island, right? The team or the player can't be angry at you if you're following some sort of guideline that's been established, versus them getting second or third opinions from other sports ophthalmologists who may say the opposite, right? It'd be nice to sort of have some sort of consensus. And honestly, even better if like you had some sort of panel of doctors. So one person couldn't be like the bad person who's saying that this needs to happen or that needs to happen. I think, again, doctors don't like the idea. And I myself can rebel against the idea because like you may be giving up some degree of control. And then you have to make sure that organization is going to be trustworthy and they're going to do things right. And they're not going to, are they beholden to any entity? There's all these things that come up when you start going bigger. But I think at the very least, some sort of loose, informal organization as sports ophthalmologists would be really nice so that guideline papers, things like that could exist. And maybe they do. I just maybe don't have the knowledge to know, hey, is there a guideline sports ophthalmology paper for basketball players? Is there a guideline sports ophthalmology paper for baseball players? I don't know of that resource, even if there are textbooks, but it'd be nice to have preferred practice patterns for each one for different types of injuries.
Yeah, I agree with you. Last question. Do you have a favorite sports team?
I laugh because, I still love sports, but it's funny. Sports has changed a lot in good ways since I was a kid, where I think most people are more tied to individual players than to laundry now, is what they say. Like, there's less attachment to team than to player. I mean, to player than to team, because the turnover of players is so much greater than it was 15 or 20 years ago. You know, if you were rooting for the Miami Heat, which was my team when I was a kid, they had the same core for 5 or 6 or 7 years. Because of improvements in player contract negotiations and player freedom, it's just not the same. Players turn over all the time. I will say, so my favorite teams were the ones I grew up with, the Heat, the Dolphins. I have a soft spot for the Golden State Warriors recently because of Steph Curry. My uncle introduced me to the Chiefs when I was a kid. That was actually my first football team. So I have a soft spot for Patrick Mahomes, but I've just tried to evolve. I'm not good at this. I've tried to evolve to a point as I get older.
Well, thanks so much for coming on. Really appreciate your time, and it's been fun talking about sports ophthalmology with you. Appreciate it, Dr. Sridhar.
No, thank you for doing this. This is a great idea, a great forum. If there are other sports ophthalmologists you'd want to talk to, I'm happy to recommend some people. There are people much more, maybe who have actually served as team ophthalmologists who could talk a little bit. Again, there's HIPAA things, but they could talk a little bit more generally about their recommendations. And I'm just glad I can contribute. Thank you for having me.
Thank you for listening to Sports Ophthalmology. To stay connected and learn more, you can find us on Twitter, YouTube, and at our website, sportsophthalmology.com.